Yeah, you can. We'll see if we can run. This is called a Mac man living in a PC world. This is not good. When Julie asked me to talk about what do you guys want to talk about? I don't know, because Julie wanted to talk about anesthesia drugs, which is a big topic. I'm going to try and compress 12 years of training into 40 minutes. So I really don't have an idea, so what I thought I would do is let's just do like a big, broad brush overview of what we do and why we do it. And the rules of this, if at any time you got a question, you want to dig deeper into something else, let's just stop and do that, because there's too much to cover. If there's any time you want me, or I can convince one of my young partners to come do a more in-depth lecture on any of these, be happy to do that, because we use a lot of drugs. I tried my hardest to make a video clip of Cheech and Chong, but you guys probably don't know who they are. But when I was doing that, I realized that looked like Dr. Erickson and Dr. Enzer in their early days, learning about drugs, but I couldn't make it work. So anyway, well, let's start with, okay, this is when we talk about anesthesia, what we do is we're trying to achieve 5 things for every patient who comes to surgery. First, we want to make sure they're analgesia, have no pain. Amnesia, that's a plus or minus. You may need someone amnestic, you may not. There are people who would rather be awake for their surgery, like if they're having a local or a spinal. Like certainly women having C-sections, you don't want them to be amnestics. They would like to see their baby and remember their baby until they're teenagers, then they want to forget them. But so that's a plus, sometimes not, sometimes there. Hypnosis is just sleep. And I separate those because it's important for you to remember that sleeping and amnesia are not the same. People can be asleep and still remember. What we find in people having a general anesthetic is the last sensation to go away is hearing, probably because it's the most primitive of all of our senses, and it's controlled deep in the midbrain, so that's a hard one to go away. So sometimes people will be asleep and they'll remember things that were said, which often results in a very large lawsuit, because we teach people to be very careful what you say in the operating room, because people may remember it. So those are 2 separate things. Muscle relaxation, again, something depends on the surgery, whether you really need someone to be relaxed or not. And the last thing is physiologic stability. Basically, our goal is to have somebody come into surgery, go to sleep, have a major trauma occur to their body without them ever knowing that anything happened to them, without their body ever realizing that there was any changes. So let's start with analgesia. We're getting pretty simplistic here. Just review, and I don't know what level you guys want to be at, but if we start with just remembering the pain pathways, our little friend here stubbed his toe. That toe could very easily be a surgical incision. And if you start actually where the site of the injury is, there is all kinds of chemical mediators of inflammation that all rally to that place of injury, and those chemicals do a lot of damage to the invader, but they also hurt us. And I don't know if you can see, there's 2 different nerve fibers that will carry pain. There's the little tiny ones, we call them C fibers. They don't have any of that myelin sheath, which is a fatty sheath that makes nerve conductions go quickly. They don't have that. And then the bigger ones, the A fibers, will carry the nerve up the peripheral nerve into the spinal cord, and then it goes up north to the brain. I'm gonna stand. Can you do my next thing? Can you handle the next generation? You're the next generation.
I hope so.
Okay. It's gonna be.
Show you next to?
No, not big. So into the spinal cord, goes up the spinothalamic tract, all the stuff you're trying to forget. Into the brain. What's important here is that in the thalamus, it's kind of the center where it spreads it out into the brain. Both to where you feel it, so you know where you're feeling it, and interesting enough, goes to the limbic system. So there's That's your emotion. So there's a lot of emotion that occurs with pain. Next. So if we so what we're trying to do when we're trying to provide, we can address that pathway anywhere we want to try and stop the pain. We can start at the site of the trauma, and the drugs we use here would be local anesthetics or anti-inflammatory drugs. We can block it at the point of the peripheral nerve, again, local anesthetics. This could either be a peripheral nerve block, like an interscalene block, a femoral block, a popliteal block. We can block it at the spinal cord, either with an epidural or a spinal anesthetic. Or we can just block it at the brain, and those are opioids. And next. So let's start at the end of at the beginning. So when you hurt yourself, there's all kinds of these bad things that are produced. It's working, Steve. Thank you. So, and these are all made by your body in response to injury. So we have drugs to try and prevent these being made. So we start with NSAIDs, non-steroidal anti-inflammatory drugs. People throw little, abbreviations out all the time, and half the time I don't know what they are, so don't be afraid to ask. So there's a gazillion of them. Really, there's 6 different classes, there's 20 different drugs. They all inhibit this enzyme, cyclooxygenase, which converts arachidonic acid to a variety of prostaglandins, thromboxanes, and you can see my typing skills are not so good. That should be an A, not a J. So by blocking this enzyme, you block the formation of these things, which inhibits inflammation and cuts down on pain. So when we're ordering a Toradol, next, that's what we're shooting at. That enzyme has 2 isomers, 2 different kinds. One is good, COX-1, and that's found everywhere. That kind of regulates, it's involved in regulating all kinds of normal functions in your body, including your platelets. The other brother, COX-2, is one that just kind of shows up when there's inflammation and injury. And we see it in the brain, the kidney, bones, and for some reason, I'm wondering if this has something to do with menstrual cramps, but I'm curious. But it shows up in the female reproductive organs. And this is the one that really is key in that inflammatory response. This one we call kind of a housekeeping enzyme. It's just everywhere. It just helps keep things running normally. This is the bad brother that comes out when things are not right. So this is the one we like to stop. So our concerns when we give these NSAIDs, either you see like some of the ortho guys have been giving like Celebrex pre-op, or we give Toradol intra-op or post-op, is to try and stop the inflammation and the pain that comes with it. The problem is, I said they're on the platelets, so they interfere with how platelets stick together, so it can cause bleeding. It also can interfere with how the kidney works, and they're damaging to the kidney. They cause ulceration. And there is some, this is debatable. When you deal with your orthopedic surgeon, sometimes you get people come in post-op with a OIRF of a fracture somewhere, and some of the surgeons believe that it impairs bone healing. First was study of spinal fusions, and there was some concern that people undergoing spinal fusions that got Toradol or other NSAIDs, the fusion wouldn't take and wasn't healing. And then the other orthopedic surgeons, not to be outdone by Dr. Sweet, the spine guy, said, well, hey, wait, I got broken bones too. Maybe that maybe it impairs that too. So they all got afraid to use it. Now, scientifically, when you study it with good studies, look at it closely, it doesn't work. However, we're dealing with surgeons who often don't care about science, they care about what they think. So this is why you get sort of this spotty response. So you call a surgeon and say, can I give Toradol to this patient? One guy says yes, one guy says no. This is what they're worried about. Okay. And then this is, I put this in there just because it shows I'm old and smart, but there is a concern I hear people talk about is, oh, this patient has asthma, I can't give him Toradol. Well, that's not correct. What you find very often in medicine is that people find something that's true in one area, and they say, well, if it's true here, it must be true everywhere. and this is why I put this, Samter Tryon, of course this is Dr. Samter, because being egomaniacs we name stuff after ourselves because that's how we are. There is a certain subset of patients who have a triad of, they have nasal polyps with chronic sinusitis, and they have an asthma or bronchospasm triggered by aspirin. So this was first described in 1902. I was not in medical school then. but actually in the late 60s this became apparent. So people took that and said, oh geez, if these people have asthma, we give them aspirin, therefore asthma and all those drugs like that must cause asthma. Not true. There's probably about 3 to 8% of the population of the asthmatics will have asthma triggered by aspirin or non-steroidals, but that's a tiny percentage. Think how many people are allergic to penicillin. It's really not much. So people took this, they saw this happening, and because I hear people say, oh, I can't give Toradol, he's got asthma. No, that's, no, not true. It comes from, it's the old little bit of knowledge is a dangerous thing. Someone heard about this and then just made a leap of faith that, all of a sudden they're all bad. Now, caveat to that is, Dr. Provenzer's or Lane's sinus people, those are pretty likely, to have nasal polyps and have this. Those people I would be a little bit more concerned with because they may be some of these people, but not the general population. And these are all the COX-1 functions. So this is where we've developed over the years these drugs that are supposedly selective only to the bad brother, COX-2. So then using these, all of this stuff is less of a concern. But a lot of our drugs, like Toradol is just a general, it blocks both of them. Aspirin blocks both of them. But it's only like the Celebrexes and some of the oral ones we use that are specific to this, so they're less of a concern. Next, please. Okay. Any questions? Non-steroidals? No? Okay. The other place we're blocking, remember, at the tissue site is a local anesthetic. These all work because they reversibly, that's the key. We like reversible in our world because some things aren't. It blocks sodium channels, which prevents transmission of nerves. We can use it either as an infiltration when you guys start an IV, there's a little infiltration. A field block is just basically infiltration, but in a bigger area. You guys don't ever see it, but you ever have patients come back with a beer block? What we do is we take an arm and we just take a big rubber band, exsanguinate all the blood out, put a tourniquet here, and then fill the veins with 0.5% lidocaine. So that's basically you're blocking this whole field with the lidocaine. And something the surgeons will use is sometimes when they've got big incision, they're just local everywhere. Works at the peripheral nerve, epidurals and spinals. 2 classes, the amides and the esters. So these are the ones you use most commonly. For us, it's important they're hepatically metabolized, and these are the ones you can have allergic reactions to. They're really rare, like reportable. Most of the people who said they're allergic to the locals is they got an intravascular injection and had epinephrine in it, and everybody freaked out and said they're allergic to it. So it's very rare. And these are your lidocaine, bupivacaine, that's all Exparel, is bupivacaine, that they've chemically wrapped in like little spheres of fat. They take a bupivacaine bottle and you sort of surround it sort of like a chocolate candy egg filled with marshmallows. The chocolate is fat, and it makes it absorb slowly. So but it's just basically bupivacaine. Ropivacaine, which is basically bupivacaine, but in biochemically it's the levo form as opposed to the mixed form. So all you've done is you've rotated one molecular bond. What this did was it gave it less cardiac toxicity, which is why we like it. So just by switching a chemical direction of one chemical bond, for some reason, it doesn't hurt the heart as much. Mopivacaine, which sometimes you'll see we use, especially with when we do blocks for AV fistulas, because and this is a drug I've never seen, but it's a demo drug. Next. We don't use it. but it's, and the esters, not Feder, this is the other esters. These are interesting for us because their metabolism is in the blood, so they don't depend on any organs to make them go away. They don't really have any allergic reactions, but they do have a lot of negative local irritation reactions when you use them locally. I don't think you guys ever use them because mainly they're either in, we use these in spinals, in epidurals, and they're topical, which is probably why, this is probably why we don't ever use them, you know, to numbing people because they're irritating. But it's okay on the mucous membranes. So like this is Hurricane and all that spray, you guys seen spray and stuff that's tastes terrible. Cocaine, Stephen knows all about that. Mucosal, and also causes vesicle. We used to use this all the time in ENT. ENT used to pack people's noses with 7% cocaine solution pre-op and just let it soak in because it vasoconstricts, cuts down on the bleeding. Not out of favor probably because it's too easy to abuse. Next, please. And how do we choose a local anesthetic? Well, its potency and duration is a function of the drug, and that's all related to how lipid soluble it is. So the bupivacaines or pivocaines are very lipid soluble, so they're slow to onset, but they last a long time, and they're also more potent because the whole goal of these is you're trying to get it across that fatty myelin membrane. So if it's lipid soluble, it'll move across to get to the nerve. So that's just how we choose it. How concentrated it is depends on the density of the block. And when we say density of block, we're talking about, if you remember, you have the different, you got those little tiny C, little skinny C nerve fibers, and you got B fibers, so a little bigger, and then A fibers, which are very big. The bigger the nerve, the more concentration it takes to block it. C fibers, which carry pain, and your sympathetic system, are easy to block, so low concentrations will block that. If you want to block muscle, motor nerves, you need a higher concentration. So we decide what do we need. Do we need to block pain, or do we need to have pain and motor block? If we want pain and we just need a low concentration. We want motor and actual pain and deep sensation. We want something more dense. Good example would be in a C-section. You start with an epidural. For an epidural, we use a very low concentration of a local. That way, it takes care of the pain, but people can still move. They can push. If they go to C-section, then we just change. Same drug, higher concentration. Now their legs don't move. They don't feel. I don't know how this is. I don't know. Let's keep going. That just appeared. Concerns about local anesthetic toxicity. Usually, like I said, it's usually when you have a direct injection. So if someone's going to get a toxicity, it's when you go right into a vein or an artery. When we're doing blocks, like we're doing an interscaling block, when I touch you in this world, and not being able to touch Joe Biden here. You know, we're going right in the neck here, and there's a lot of big vessels right there. If you look on the ultrasound, you'll see a big, maybe pulsatile, and it's very easy to accidentally. That's why I always ask you guys, well, you guys don't do that, but the pre-op nurses, we want you to aspirate before you inject, because if we're directly in a vein, when we're doing an epidural, especially in pregnant ladies, there's two big veins that run right along the side of the spine that get much bigger in pregnancy. So when we are putting an epidural in, we make very sure that we're not intravascular, because years ago there were deaths from, the practice used to be just get in the epidural space, put in 20 cc's, and if you were intravascular, especially with bupivacaine, it was cardiac arrest. And it's a cardiac arrest because these drugs bind so strongly to the nerves that it's you can't reverse it. And there were case reports of doing CPR for 2 and 3 hours trying to get people back because it doesn't. We've changed our practices. That's why everything's given in small doses, a lot of aspiration to avoid this kind of stuff. When you're using those other drugs that are sprays, you absorb very well from your mucous membranes. That's why you put nitroglycerin sublingually. If you overspray, people spray like crazy. You absorb it to the point of toxicity. Something that hurricane benzocaine spray, you can develop methemoglobin from that, and I've seen that a few times where especially ER docs, they just start spraying stuff. And then they develop a methemoglobin, and methemoglobin doesn't carry oxygen very well. So it's basically, you've got a lot of hemoglobin, but none of it's carrying anything. And with lidocaine, you could get toxicity. And when people get toxic, they go through stages. They start out with first neural excitement, kind of jittery, I don't feel right, things aren't, you know, it's like I've had 20 cups of coffee, may have ringing in my ears, you know, tingling in my mouth, just odd kind of feelings. And that will progress to, and then they'll become depressed, neurally depressed, somnolent, sleepy. Then they'll go into cardiac excitation, dysrhythmias, tachycardias, ETAC, whatnot, to eventually just cardiac collapse. If you remember, these drugs are meant to stop any kind of electrical transmission of anything along your nerves. That includes your heart. And if you get enough on your heart, you need that little EKG thing. That's all electricity. So if you block that, that stops. And then next. So for you guys, you can go to another one of those random slides. So you're in a recovery room, and someone starts to, and they've had a big block, or they've had the surgeons put 100 cc's of local in there or something, and they start acting kind of weird, getting all excited. It's time to, your hairs in the back of your neck, your spidey sense should go off. This is something I got to watch a little closer. About 10, 15 years ago, somebody had a great idea. Well, if these things are lipid soluble, what if we just put a bunch of lipid there and let them, you know, bind it? And it seems to work. So if you have someone who's toxic, and we get our lipids from the pharmacy, and it's just the same TPN lipid that we use on the floor. So it's a 20% lipid solution. And it sort of sequesters the drug harmlessly in this lipid so it can be metabolized later. The dosage, and there'd be a cart there, but it all depends, you know, this is little people, this is not little people. There should be a cheat sheet with it, because whenever if you're going to use a lipid, and I've never used it, but I've seen it, heard of it used a few times, if you're into that, it's like MH, if you're into that point, everybody's nervous and forgetting. Basically, you dose it by cc's. You know, 1.5 cc's per kilo, then you follow it with a drip, or if they're bigger, just 100 cc's, just push. Any questions? I think that's all on.
So do you always give a bolus
Yes.
and then you start a drip, but
Yes.
not always start a drip, or may?
You always do bolus
You always
followed by a
do.
drip.
Okay.
With the bigger people,
So I
it's
think
a
one
drip,
time-
and then it's like over the next
We've
20
only done
minutes,
it
you
like
give another
once,
2
I
or
think,
2.
haven't we?
Yeah,
I
well,
did
one
do it
time we
once or
did it, and
twice.
I think there was, they needed clarification, and that's why we made up that lipid
Right.
folder,
Also,
because we didn't know if it was supposed to be just a couple syringes, or you're supposed to follow it with a drip.
With the adults, I think it's just a bolus, and then you're going to give another 200, 250 cc's over 20 minutes. You want to drip that, you want to put it in a pump, you want to stand there and do this,
Oh, okay,
whatever.
so it doesn't matter, just
Smaller
you're giving it
people, you
slower.
put it on a pump. And I think that's aimed at kids, you know, so you're using a little kid, and then it's harder to be that precise. So, seem right? Yes, no?
Yeah,
Okay.
no,
Okay.
no, it makes sense.
Okay. Locals in a nutshell, okay. Narcotics, my favorite drug, God's own anesthetic. Because we make endorphins, which our brain and our body make opioid drugs. I figure if God's we've got to put opioid receptors in my brain, that's what he wants me to use. So the other thought is, you know, narcotics make your pupils pinpoint. You ever heard the expression, the eyes are the window to the soul? No, you know, oh my God, don't they teach poetry anymore? Okay, poetic time back then. Your eyes are the windows to your soul, right? So when you give them narcotics, you make the pupils small, the soul can't get out, so they're safe. But, so narcotics have,
I'm giving a bunch, yeah.
there's a variety of different receptors. There's mu receptors, kappa receptors, delta receptors, zeta receptors. The ones that are important to us are the mu and the kappa, and there's 3 of these and 3 of those. But you find them in the brain, the spinal cord, and around peripheral nerves, which is why you'll see some of the surgeons, ortho guys, will inject morphine and stuff into joints. It seems odd. They're not depending. They don't know it, but they're not depending on systemic absorption, they're actually addressing the view receptors at the peripheral nerve where they just damage itself. So, but they read a recipe, they give it, they don't know. So, and these receptors mediate analgesia, they're great analgesics, respiratory depression, euphoria. People feel good with narcotics. Long ago, we used to give 100 of fentanyl in pre-op because people feel good. You know, if they didn't feel good, they wouldn't be abused, correct? So you know that narcotics make you feel good. Unfortunately, they do this too. So now there's a huge. Now we're going crazy nuts this way. That narcotics are bad. Narcotics are not bad. It's like everything. My mom always told me everything in moderation, except moderation. But if narcotics are good, you need them. The key is to pay attention. People are very concerned about overdoses and dependence. Not an issue for us. You know, this is post-op.
Fell carried away there.
That's okay. And the other one, there's a delta. So the ones we use and the ones you see, we have fentanyl. These are all synthetic drugs. So they're you'll often see. So they're made in the lab as opposed to grown in poppies, like morphine and opium and all that. Standard is fentanyl, which I always compare things to morphine because that's been around forever. So fentanyl is 100 times more potent than morphine, which is why you're seeing, this is what's, this rash of opioid deaths we're having is because there's fentanyl coming from China through Mexico to the border, and they're mixing in with other drugs to make them more potent. Well, when you get some guy in a lab down in China, you know, it's not very precise science. So when you think you're getting one dose and you've got a drug in there, it's 100 times more potent. It's easier to die. So this is why we're having a problem. Sufenta is even more potent. That's 10 times more potent than fentanyl, so it's 1,000 times more potent than morphine. Great drug. Remifentanil, which you see a lot of people coming from spines. Okay, it's about twice as potent as fentanyl. It's very rapid onset. Comes on quickly, goes away quickly. That's why people like it. Very expensive. I think 2 milligrams is like $1,500. So we got these. This was a drug that was designed for short cases, not long spines. I mean, it's like $1,200. So you may end up spending, and that's drug costs, patient costs at 8 to 10 times that. You know, because the pharmacy, what it may be patient costs, but it's still a lot of money. You know, when you're dropping $8,000 as opposed to like $2.50. You know, this is. But it's easy to use because it's quick on, quick off. Trouble is it goes off quickly, so there's no analgesia after surgery. Which is why I don't know if you guys noticed that Dr. Sleva started giving his patients intrathecal narcotics because so many people are using this. Their people wake up in pain. And they wake up in pain in the OR, and it takes a while to, you know, that's a big incision that hurts. It takes a long time to catch up with their pain. So he's had to add something to bridge the gap between this and the time they get to their PCA. And actually this has a rebound hyperalgesia. So when it goes away, not only does it go away, doesn't provide any analgesia, it has a hyperalgesia. There's a few drugs out there that when they're in low doses, they actually make you more sensitive to pain. That's one of them. So fentanyl, we don't have it here. Maybe this thing's. It's not very potent. It was sort of the rapid acting before this came along. It's only about a third as potent as fentanyl. Bad. I'm good with that too. Next, yeah. And the semi-synthetic, you're used to these, the morphines, hydromorphine, Dilaudid, and oral. Okay. Talk about those. Pros and cons, great analgesia, very stable. We used to do hearts, this would be your soul. It's so cardiac stable when we used to do hearts with just narcotics. We would give 100 cc's of fentanyl. You know, you just push 100 cc's of fentanyl and it was perfectly steady. Great analgesia, but no amnesia because they can have a great effect. I've known people who forgot to add in an amnestic with it. One of my friends, after he visited his patient post-op after their heart, says, "Oh, everything was fine, good, but I didn't realize I was supposed to be awake." And he goes, "What?" And she described everything from sternotomy, sawing her sternum coming open, going on bypass, and the last thing she remembers hearing was, "Let's do it," which was what go on bypass, because he forgot to give her version. At this time it was Ativan, or he forgot to give any kind of amnestic. And that's a good case that she was asleep, to everyone in the room she was asleep, but she recalled, didn't bother her, it didn't hurt, So a great analgesia, no amnesia. It's really good antitussant. What?
I think my heart rate would be like,
Well,
I could hear, but I couldn't,
Well, that's, yeah.
it'd still be.
I got a
think
whole
you
lot of
wouldn't see
lecture
it
here
any
about
other,
awareness.
like,
That's kind of-
symptoms.
Yeah, that's scary for us, that people might remember. Very scary. Great cough suppressants. So when you ever had really bad cough or pneumonia, after you finish your Ricola drops, they're not working, you move on to codeine. Great cough suppressant. Well, we do a lot of things that, when we intubate people and stuff stops down their throats, they gag, they cough. These are great at blocking that. So these are good to put in. We give these before we intubate people just for this. And then it cuts down what you need for other anesthetics. We try and use a little bit of everything, so we don't use a lot of one thing, because usually you run into side effects when you use a lot of stuff. Bad things, respiratory depression, they can cause bradycardia. They can accentuate, and this usually comes from operator error. If you forget that I've given these narcotics, I don't need as much as the other stuff, then I just go ahead and use as much of the other stuff as I normally do. It accentuates that. Some post-operative nausea and vomiting, mainly with the oral stuff, the post-op pain stuff. Morphine's the worst, alfentan and dilaudid, fentanyl and sufentan, as far as nausea goes. So if we go back to our little train of pain train, there's other drugs that we don't, I'll just briefly mention that we use to try and block pain. The alpha-2 agonist is a clonidine or Precedex. Have you guys used Precedex before? It's a good analgesic. It's calming because there's alpha-2 receptors in the brain and in the spinal cord, so it provides analgesia and some sedation. It's nice for use it for thoracotomies. You get analgesia and they're pretty mellow. The anticonvulsants, these are the gabapentins. You see the surgeons coming pre-op taking their Lyrica and gabapentin, because they don't know it again, but they're actually working at the peripheral nerve to try and block stuff, because they're good for neuropathic pain. And then, I know one you had questions are the NMDA that's ketamine. So to go on, let's see if we talk about. I think I oh yeah, there you go. A few of my young friends are now on a ketamine kick. This is a drug that's been around forever. It was popular a little bit in the 80s and kind of went away. It came back in the 90s and kind of went away, and then for some reason it's back again. Usually when things go away, they go away for a reason. And this is the NMDA, is the N-methyl D-aspartate receptor. They're all over the brain, spinal cord, and it blocks that. Great analgesia, great analgesia. And you can use it as a sole anesthetic, or you can use it for people to sleep. So, really rapid onset. Used to use this for crash C-sections because it's so fast on. And you could mix it in a syringe with your ketamine, succinylcholine, with one syringe you could have to lay to sleep. Great analgesia. Sometimes we'll use it in OB if there's an epidural is spotty and the lady's feeling pain. You get little 10 milligram hits of ketamine, and it's a great analgesia. It maintains your blood pressure and your heart rate, so it keeps your cardiovascular system up and running. Nice bronchodilator. People will keep breathing, so it's not like narcotics and other drugs. They'll keep breathing with this. And the reason it's popular, again, is with the sort of overreaction to the narcotic crisis in the world. The people trying to do everything they can not to use narcotics, even when they're needed. This you can spare using narcotics. It is useful for people who are chronic pain people who are on You know, you see these chronic pain people come in, you look at their drug list, and how are you alive? There's so many drugs here. This seems to help them get through surgery, but it has to be given as a constant infusion through surgery to block that. And people who are just refractory to narcotics, this will help them. Bad, this is, I don't know if you've ever heard of the word angel dust, this street drug, angel dust. Ketamine is often abused on the streets. People have wild, crazy dreams. And I, you know, some of my nurses will use it, but they don't get the phone calls from the patient who's foot flipping out on the floor, having weird dreams and recovery. And this is because it's like LSD. It's just, I know my dog had this, vets use this a lot, it's a big veterinary drug. I know when my dog had surgery on ketamine, he was like Cujo for 6 hours. My wife was scared of him. He just had to stare, like I'm gonna kill you. So people don't like that. The way it provides anesthesia is called dissociative anesthesia, where people, within your brain, they literally, their consciousness is separated from their pain. So they'll remember things, like I used it on a cardioversion once, so when the patient woke up, he asked me very calmly, he said, "Did you take my heart out?" And I go, "No, why?" He said, "No, you took my heart out and then you turned it around and then you put it back in." And I said, "Sort of, but not that." So he remembered it, it didn't hurt him, but he remembered it in kind of a hippie-like Haight-Ashbury, LSD days. So that bothers patients. It bothers patients. Increases your intracranial pressure, it increases your cardiac workload because it does make you tachycardic. So bad for people with intracranial processes or coronary disease, bad for these people. And they drool like rabid dogs.
How long does the ketamine last? Like I've had patients come on it with like in drips
couple hours,
before, so
couple
if we turn it off, then and they go to the floor, or?
I don't know, I have to look that up since I don't use it that much. It should go away in an hour or so, a couple hours. I mean, they'll wake up and talk to you, but as far as the crazy effects,
Yeah.
I've gotten calls 4 or 6 hours after surgery. They used to mix it with their propofol. So if we go back, I'll give you a second. I don't like that drug. So if we go back to, we did this, so let's move on to amnesia and hypnosis, because we have to try to 10 minutes. Amnesia, like I said, sometimes part of it, an adjunct to regional, and this is a key part for Max, we don't want people to remember. So hypnosis, this is sleep, or we call it deep sedation. So that's when you lose response to verbal commands, which is a general, and when we talk about induction, you guys hear us talk about induction, that's really the process of taking someone from awake to a state of general anesthetic. So we use induction drugs to get them there, and we use maintenance drugs, which are usually our inhalation agents, to keep them there. And then we talk about stages of anesthesia. So stage 1 is us right here, conscious, rational, but then stage 2, they go through the stage of delirium. And the reason we use IV induction drugs is to bypass this. Now they go through that when they wake up, and when we put kids to sleep, we just have them breathe gases, and they go through this delirium, and they're just crazy. And the problem with this is they're very prone to laryngospasm. So I caution you, if you get these people come back with LMA still in them, and you're taking them out, they haven't gone through this yet. So
Does it
you're
make a difference if you give them pre-op first, or no? Do they bypass that quicker or no?
going down or
Stage
coming
2?
up.
Going down.
Yes, they bypass
They
it quicker.
bypass it.
Yes. And then this is where we're trying to keep them here. Stage 3, stage 4 is where we're done, or we don't want to be there. So, but that's fine. So we use the drugs we use to go to sleep. Propofol. You guys all know etomidate. You've seen that much. This is Brevitol and ketamine. So propofol, the gamma-aminobutyric acid. This is a real common receptor that kind of turns everything off and on, mainly off. If we block it, it turns off your spinal cord and your brain. The thing with propofol, it's an emulsion. It's white because it's basically it's water, but it's not water-soluble drug. So you have to mix it with egg phospholipid, soybean oil, and glycerol. So it's kind of an oily mixture, which is why it burns. anytime you inject this IV burn, I don't know if anybody's old enough to ever use Valium. Valium was suspended, similar was suspended in glycerol, and it hurts like hell. IM, a little bit IV. We used to give punitive Valium to drug seekers, but that's another story. We like it because they go to sleep in 30 or 40 seconds. It only lasts 3 to 8 minutes. The asterisk is, because it is lipid soluble, if they're on propofol for a long time, like on a drip, it starts accumulating all your fat. So even though you turn the drip off, it's going to last a long time because it's coming out of your fat. So it's only short duration if you use it for a short duration. So you'll see people who've been on drips for 6 or 8 hours, and they wonder why the patient isn't waking up and they haven't turned their drip down through the course of a case. This is all just packed away in your fat. So that's the asterisk. It's a nice antiemetic. For some reason, of all the drugs, it doesn't seem to cause nausea and vomiting. It's anticonvulsant, bronchodilator, is safe for kidney function. Does cause hypotension, respiratory depression, and the contamination risk, because it's got all that fat in there. It's a great medium for bacteria growth. There have been few cases of people getting septic shock injected when propofol has been open. So usually our rule is if it's been open more than 6 hours, throw it away. So because it's great for growing bugs, and it hurts. Next. Etomidate. We rarely use it. It's here because it's great hemodynamic stability. It's when people are hypotensive and shock and you want to get them to sleep, that's the drug to use because like narcotics, it keeps their blood pressure and heart rate and cardiac output normal. Oh, you want to go back? Oh.
Press the up arrow.
Up arrow. Oh, there you go. Rapid onset, good anticonvulsant. Okay, now I forgot you read the slide. Okay. It hurts too. It also has no analgesia effect, so you've got to combine this. So if you're going to just put someone to sleep with etomidate and then try and intubate them, they may be asleep, but they're going to respond to it because it hurts. So you really have to precede that with some analgesic. And cause a lot of nausea and vomiting. So, and big concern is adrenal suppression. Probably not in a single dose. They used to put people on drips in the ICU, but they all had adrenal suppression. Methotrexate, we don't use it. Some of the cardiologists use it. We used to use it for ECTs because it enhances your seizure threshold, so it was good for ECT. Anyone do ECTs?
Yeah.
Okay. We'd use it for that because it made them more
Against our will.
against your will, right? It made them they seize easier, and that's the goal of an electroconvulsive therapy. You want them to seize, so you use something that's going to make them seize. Great. We used to use that. I used to do seizure-focused resection surgery where we do brain surgery to cut out where the seizure was coming. We'd use this as the anesthetic because it would help us map to what we had to cut out. We don't use it, the cardiologists use it because it's fast, it's safe. So muscle relaxation, like I said, not always necessary. We decide to use it only if it's going to help the surgical exposure, pull people's bellies apart. Sometimes with orthopedic surgeons that get the bones to work, you'd like to relax. Helps us ventilate people. Big danger of, we talk about if someone's paralyzed and awake, they can't give you any signs. So at least if someone's not paralyzed, if they're awake, they can do this. They can make some cues that will, wake you up. And the danger, and this is postoperative weakness. This is for you guys because people have been muscle relaxed and they're inadequately versed, and they get to the recovery room, they can re-weaken. They call it re-curization. That's what that is. Talks about curare. One of my first patients in an ICU when I was a young resident was a 24-year-old guy, just got married, came in for hernia surgery. His hernia repair, he was in a recovery room. They ran out of recovery room beds. They figured he's young and healthy. They just sort of moved him off to the side, at which point he sort of got weak again, had a respiratory arrest, had an anoxic brain injury, and now he was basically a trached vegetable in the unit at 24 because the PACU just said, we don't need him. He's okay. He got re-weak. That was welcome to medicine. So The way our muscle relax, this is just my cool science slide. Okay. The muscle, nerves come into the muscle and they connect to these little muscle terminals. They spit out acetylcholine, which binds to these receptors and turn it off. And these little, within that cleft is a drug, is an enzyme acetylcholinesterase, which metabolizes that to make it go away. So all of these drugs just block that acetylcholine, that receptor. There are two types, the depolarizing, which is sucks. They actually bind and makes the muscle work before it goes weak. The non-depolarizers, which is most of what we use, don't bind to it. Succinylcholine, this is basically two acetylcholine molecules stuck together. It actually, if you guys come in the operating room, we give it people fasciculate. That's because what succinylcholine binds to your end plates makes your muscles just have this massive, they all work and then they just stop working and then they relax. I can explain the physiology at a later time. Oops. Well, part of the problem, can you go back up here again? Oh yeah, wrap it up. We like it because it goes on quick, off quick. Okay, now you go. The trouble by making the muscle actually work causes all kinds of side effects. People have muscle aches. It's like doing one huge isometric when every muscle in your body is contracting as hard as it can for 20, 30 seconds. People often wake up aching. Some of the sore throats people have after surgery are actually your muscles in your palate doing that. And it causes potassium to bump up, which is why we're afraid to use this. Just a standard dose, and you and I will knock your potassium up a half a milliequivalent. This is much worse in people who've had burns or strokes or some sort of neuromuscular diseases. Increases your intracranial pressure, ocular pressure, so people with glaucoma, not good for. It increases your gastric pressure. Also risk of malignant hyperthermia, and can cause. So it's got a lot of side effects. It's good because it's rapid on a lot of side effects, so it's preferable to use something that doesn't have any of these side effects. And these are the non-depolarizers. All of these drugs you've seen and heard of. We choose the drug just based on what advantage they may have. Something like cystatin, people with renal failure, because it doesn't depend on the kidney or the liver, it just goes away. Mimicron, which the hospital will buy for us because it's too expensive. It's as fast as sucks, but it doesn't have all of the side effects of sucks, but we don't have this next, so that's how we choose them. When we reverse them, what we're doing is we're basically giving them nerve agents, which block that, they block the acetylcholinesterase enzyme, which means that when your nerve sends a signal, you release all the acetylcholine, it doesn't go away. So what happens is you have so much more acetylcholine than you have muscle relaxant, they compete for the receptors. This wins, the muscle relaxant goes away, and you reverse. So, the trouble is that with a lot of acetylcholine, that's what your parasympathetic nervous system is. So you get this giant parasympathetic, you go back and make cool side. So it just blocks the, you go on. So, you can keep going. Because so you have to get it with an anticholinergic drug, otherwise you'll have bradycardia, mainly bradycardia, that mean like asystolic type bradycardia. These are the drugs. These are the acetylcholinesterase inhibitors, and this is a new drug, so Gamadex, which it's kind of like the lipid rescue. It binds, you can go on. It binds rocuronium. Is that it? No. Yeah, all right, so for you, we measure, first talk about train to 4 for weaknesses. If people have 4 strong twitches, all that tells you is that, well, 30% of your receptors are free. You still could have 70% receptors bound by muscle relaxants, so there's your weakness. Better to use clinical signs, a 5-second head lift. All that tells you is that, well, at least half of them are free. So you never really know how much muscle relaxant is still around. People can recuratorize. You haven't given enough time. Someone didn't do a really good job of assessing. The biggest thing is respiratory acidosis. So people who are hypercarbic and not breathing well, respiratory acidosis impairs the ability to reverse the drug. So you can start this downward spiral. They get weaker, they don't breathe so well, they get more acidotic, they get more weaker, and then this is the 24-year-old with the trach. was probably that. I think that's it.
Voila.
Well, it's 8:05, I'm 5 over. But we got five. That's my 30,000-foot view of what we did. Any thoughts, questions? Come back for another day and send Solomon to some consensus. Okay. Is that kind of what you want?
Yeah.
It is, there's lots of requests for talks from Anastasia, so I think that if we do something that is just maybe regularly set up,
Yeah, that's fine. And give us
to
more
do different
specific,
topics, and then we
more
can.
specific,
yeah.
because this was kind of like,
Sure.
any one of these things could have been a whole.
Yeah, and
You
any.
can spend a whole hour talking about narcotics, you can spend a whole
Mhm.
bunch, this was just like, this is a potpourri, this was a buffet.
Mhm.
Fancy. So,
Oh, it's good.